Good morning. Coming to second part of Introduction to Public Health, Learning Outcomes. At the end of the lecture, the student should be able to outline the principles of primary healthcare, then identify and explain the concepts of prevention. Come to tools of dental public health. The first one is epidemiology. The study of distribution and determinants of health-related status or events in specified population and application of this study to the control of health problems. Actually, in detail about epidemiology, we are going to teach you in year 4. Right now, this is just an introduction. What is epidemiology? It's nothing but the study of distribution and determinants of health-related status, or in general term, the study of disease, like how it's spread in the population. Why you want to collect that data, like how and how much is the disease burden? Because once you know the disease burden, you can plan or you can give the report to the government so that government will plan some treatment plan or some prevention if the disease burden is too high. The aim is to eradicate, minimize the disease or health problem at its consequences, to promote the well-being of society as a whole. That is the main aim of epidemiology. The second tool is biostatistics. Biostatistics is a science of compiling, classifying, and tabulating numerical data and expressing the result in mathematical or graphical form. The branch of statistics concerned with mathematical facts and data relating to biological events. For this also you have one more chapter in your year 4, I think so, or year 5 for your batch. So in detail you are going to study this one. Right now this is just an introduction class. So you should know there are two tools. One is epidemiology and another is biostatistics. Come to uses of biostatistics. It's to define the normalcy. That means whether the population distributed in normal distribution or not, and to test whether the difference between two populations regarding a particular attribute is real or occurring by chance. To study the correlation or association between two or more attributes in the same population. For example, back pain. Only students are getting back pain, or even the lecturers also getting back pain in a dental college. So that association or relation that you have to identify. By using biostatistics, you can associate or correlate the disease and the people. So this is one use of biostatistics. Similarly, we have a lot of we are going to use biostatistics in many ways to evaluate the efficacy of vaccine. Yes, you have to prove what is true positive, what is true negative, like that. We are going to use biostatistics to locate and define the measurement of extent of morbidity and mortality. For example, dental caries prevalence in Butterworth may be 60%, but in KL it may be 80%. So that geographical distribution, how we can classify the prevalence, like KL is classified as highly prevalent area of dental caries, Butterworth may be mild prevalent of dental caries. Like that you can classify it. So that is the use of biostatistics. Then to evaluate the achievement of public health program. For example, Malaysia is have fluoride program. Before the initiation of the program, the prevalence of dental caries may be 80. So after 5 years, that might reduce to 60. So that difference we can calculate by using biostatistics. And to fix the priorities, like high prevalent disease, like for example KL, I already told you. So for that we can give more priority to reduce the burden of disease compared to Butterworth, so that we can divert more money into such areas than those having lower prevalence of disease. Come to preventive dentistry. It encompasses all the dental practices that affect overall health status at individual and community level. So levels of prevention is primary, secondary, and tertiary. The goals of prevention is to promote health, to preserve health, to restore health, then minimize suffering and distress. Come to primary prevention. You should think primary prevention means disease has not occurred. So you are taking the action before disease has not yet occurred. So the first is action taken prior to the onset of disease that eliminates the possibility for the occurrence of disease. It is more than just preventing the disease and promoting health. It's a concept of positive health encouraging achievement and maintenance of acceptable levels of health. Enable every individual to lead social, economically productive life. So primary prevention is nothing but before disease has occurred, you are going to prevent it. For example, doctor might suggest you to do daily exercise or run so that you will be fit and fine, you will be immune to so many diseases. You should have proper diet, you should maintain your personal hygiene. These are some of the primary prevention methods. So advantage is low cost for maintaining your personal hygiene. What maximum you want soap or Dettol, something like that, taking everyday bath, wearing a good cloth, then for example safe driving, then comfortable, then easy. So this is very cheap method of or economically very good method of taking prevention against the disease. The approaches for the primary prevention is primordial approach. In this, prevention of emergence or developmental risk factors in countries or population groups in which they have not yet appeared. The major intervention is by individual and mass education. Efforts directed towards encouraging balanced diet. For example, Malaysia is having more obese patients. So Thailand might have less obese patients. So once using biostatistics, we have come to know that the Malaysians are having more obese patients. So that through the community effort and through the Ministry of Health, we can create like mass education of people against obesity, so that we can tell them to go for regular exercise and to reduce their weight and taking balanced diet, which is most important. Then population or mass strategies directed at the whole population irrespective of the individual risk level so as to bring about behavioral and lifestyle change. Example, the betterment of average oral hygiene status of population would decreases the incidence of dental disorder. Like for example, you can use some television channels to demonstrate proper brushing technique and how to keep oral hygiene in mass. So we can give individually also, we can give mass also. All the education like health education materials will be prepared for both individual, community as a whole population. Come to high risk strategy. Here you have to concentrate on the term high risk. It's stating only for the high risk people. For example, old age. During our COVID pandemic, those who are aged above 65, they are more prone for morbidity. So they are high risk. So like that, we have to classify high risk and low risk people. Then we have to concentrate or you have to divert the preventive measures for them. So modes of primary prevention. First is health promotion. The second is specific protection. Now we will discuss what is health promotion. It is the process of enabling people to increase control over and to improve health. It is not directed against any particular disease, but it is intended to strengthen the host through a variety of intervention like health education, environmental modification, nutrition intervention, behavioral changes, lifestyle adaptation. You have to remember everything because you can put anywhere in your answer in community. So I'm telling you, you have to remember everything. First is health education, environmental modification, nutrition, behavioral changes, lifestyle adaptation. This you have to remember because you can put this anywhere while writing the answers in community. Specific protection. This is the second method of primary prevention. In this, provision of condition for normal mental and physical functioning of the human being individually and in the group. It includes the promotion of health, prevention of sickness, and curative and restorative medicine in all its aspects. For example, fluoride application or patent visual sealants for caries prevention. This is the specific protection for caries prevention. Then comes the secondary prevention. In this, action which arrests the progression of disease at its early stage and prevents further complications. For example, screening. It is mainly based on early detection and diagnosis and adequate treatment. The earlier the disease is diagnosed and rectified, the better it is from the point of view of prognosis and preventing further complication and long-term disability. Advantage: reduces high mortality and morbidity, interception of prognosis of the disease. Disadvantage is very expensive. Tertiary prevention, this is more expensive. All measures available to reduce the limit, impairment and disability. Here disease has already occurred and it's already damaged. Then you are taking this prevention. For example, all the disease like all the posterior teeth as lost by a person. What is the treatment? Either you have to go for complete extraction and giving complete denture or partial denture. So that is rehabilitation. So that disability you can be treated. So in the tertiary prevention there are two types: disability limitation and rehabilitation. In the disability limitation, the objective is to prevent or halt the transition of disease process from the impairment to handicap. For example, the first teeth is lost due to periodontal disease like lower anterior. So suddenly if patient is aware that other teeth will also have the same problem, then he comes to dentist, then we can treat other tooth so that the loss of teeth can be prevented. If we don't want to come, then you will land up in rehabilitative. That is very expensive. Here only in the flap surgery we can do and we can control it. But if you go for rehabilitation, he has to go for extraction of all the teeth and for complete denture. Then preventive procedure. First is parental counseling and prenatal and postnatal. This is for the pedo patients. Then caries control. Then space maintenance, exfoliation of deciduous teeth, treatment of abnormal frenal attachments, treatment of locked permanent first molar, that's impacted first molar, locked permanent first molar, abnormal oral musculature habits. Come to caries control procedures. First and foremost is diet and oral hygiene maintenance, then regular checkup, fluoride applications, prophylactic orontomy, patent visual sealants, restorative procedures like silver amalgam, glass or cements, then immunization. Diet and oral hygiene maintenance. First is balanced diet. Balanced diet contains variety of food in such quantity and proportion that the need for energy, amino acids, vitamins, fats, carbohydrates and other nutrients is adequately met for maintaining health. Carcinogenic potential of food depends on many variables such as presence of fermentable sugars, ability to retain by teeth, ability to form acids, ability to dissolve enamel. This we are going to teach you in year 5, like how caries, like diet is related to caries. Regular checkup is foremost important. The parent should bring their child for first dental visit early, at least by the time the baby is 6 months old. Frequency of recall visit have to be decided according to the individual needs. Usually a 3-month recall checkup is advised to monitor oral hygiene status. Half-yearly visit to dentist should be a routine for everyone. Then the immunization. Immunization with streptococcal mutant should induce an immune response which might prevent the dental caries in the following ways. It will prevent ability of the organism to colonize onto the tooth surfaces. It can alter the pattern of polysaccharide metabolism by bacteria and thereby reducing othering capacity on the tooth surfaces. Oral administration or subcutaneous injection of killed Streptococcus mutant can be induce the formation of specific immunoglobulin A, immunoglobulin G and M in blood. But this is not yet in the market, but some countries tried, but success is a little difficult, so other countries are not following this. Come to healthcare. Multitude of services rendered to individuals, families, or communities by the agents of the services or professionals for the purpose of promoting, maintaining, monitoring, or restoring health. During first half of the century, two great movements were initiated, that is, provision of basic health services through the medium of primary healthcare centers and sub-centers for rural and urban areas. The concept of health centers was first mooted in 1920 by Lord Dawson in England. The second movement was community development to promote village development through active participation of whole community and an initiative of community. Levels of healthcare, that is primary healthcare, secondary healthcare and tertiary healthcare. Primary healthcare, it is first level of contact between the individual and health system. For example, in the rural area, if the rural people wants any healthcare facility, they will visit primary health center. So that will be the primary healthcare. Care is provided by primary health centers and sub-centers. Come to secondary healthcare. This is more complex problems are dealt. Like for example, here only class 1 cavity will be treated or 2, but here we have to treat even class 3 access opening, everything, root canal treatment. So to provide secondary health care, most of the countries have district hospital and community health centers. Then the tertiary health centers, these are super specialty hospitals, offer super specialty care given by regional or central level institutions. Excuse me. Supports and complements actions at PHC. It's like referring. When we can't treat patients in primary health center, we will refer to secondary. When we can't treat in the secondary also, then we will refer to tertiary. Tertiary is the last one. Here we should have all the facilities. So primary healthcare, it's an essential healthcare based on practical, scientifically sound and socially acceptable method and technology made universally accessible to individual and families in community through their participation and at the cost that community and country can be offered to maintain at every stage of their development in the spirit of self-determination. See, primary health care or primary health centers are available in the rural areas, and the availability of the resources are the needs of the people should communicate each other, and they should inform the PHC people or primary health center people, or else those who are sitting in primary health center, they will not be knowing what problem are faced by the community. So first and foremost is community should participate equally and they should share their problem to the doctors. Then only the primary health center people can help them. The concept of primary health care came into existence following a joint WHO and UNICEF International conference at Alma-Ata. In order to provide services, a simple and sufficient regard to cost, technique and organization, then readily accessible to those concerned and contributes to improving the living condition of individuals, families and community. It is based on principles of society, equity, nationwide coverage, self-reliance, intersectoral coordination, and people involvement in planning and implementation of health program in pursuit of common health. So What are the characteristics of primary healthcare? It is essentially which is based on practical, scientifically sound and socially acceptable methods and technology. It should be rendered universally to individuals. Its availability should be at cost which community and country can afford to maintain at every stage. It requires joint effort of the health sector and other health-related sectors. Primary healthcare reflects and evolves from the economic conditions and socio-cultural political characteristics. It also addresses the main health problem in the community. It should be sustained by integrated, functional and mutual support to referral system, leading to progressive priority to those most in need. Elements of primary healthcare, that is Alma-Ata Declaration, as outlines 8 essential components of primary healthcare. The first is education about prevailing health problem and methods of preventing, controlling the same. Then promotion of food supply and proper nutrition, an adequate supply of safe water and basic sanitation, maternal and child health including family planning, immunization against infectious disease, prevention and control of endemic disease, appropriate treatment of common disease and injuries, provision of essential drugs. This we will ask for sometimes 5 marks and sometimes 2 marks. So you should know what are the elements of primary health care, primary health centers. Coming to principles of primary health care, the first is equitable distribution. What is the meaning of equitable distribution? That is nothing but health service must be shared equally by all people irrespective of their ability to pay, irrespective of their economic status, religion, or cultural habits. All are eligible to take facilities of the government. That is nothing but equitable distribution. Second is community participation. The involvement of individual, families and welfare is essential. The community must involve in the planning, implementation and maintenance of the health services. Why I am stressing on community participation means without community participation, none of the policies or planned things will be successful. Everything will be failed. So, for example, yeah, if known person in the community or head of the community come and speak with medical officer in the primary health center that this is the problem in our community, then that medical officer will come to know some problems in the communities, then he can plan for remedies for that. So community participation is very important. Then comes appropriate technology, like for example, to treat dental caries we need our dental chair and other things and restorative materials and a dentist. Like that, appropriate technology for appropriate disease to treat. So it should be effective, acceptable to those who apply, capable of further development, simple to design and use, easily understood by the people. Then comes intersector coordination. For example, how we can keep environmental clean so that our health is also good. So there will be here MPSP, they will clean the community waste and all, so that they are keeping our health in good. So intersectoral coordination, PSC people will tell MPSP to clean the dustbin or water purifying unit, everything they will check, so that there should be coordination between water purifier, MPSP, then primary health center. So intersectoral coordination should be there. And then this is one of the principles of primary health care. Then comes on focus on prevention. Prevention is better than cure. So always we have to focus on prevention. That is, primordial prevention is always better than primary prevention, then secondary and tertiary. But primary prevention is well accepted. We have to follow primary prevention. So historical background of primary health centers in Malaysia. Yes, Malaysia spelling mistake is there. Malaysia is inherited a health system from the British upon independence in 1957, but mainly in urban areas. Healthcare services was expanded as a post-independence priority, particularly for the economically disadvantaged and rural population. The three-tier primary healthcare model developed for the public sector which includes healthcare center, 4 subcenters and 4 midwife clinics for each subcenters. The subcenter tier was demolished in 1970 and midwife posts were replaced by community nurse clinics in order to provide more comprehensive care. At independence in 1957, there were 10 major hospitals and 56 district hospitals plus 7 institutions for leprosy and mental health patients. From 1960 to 2009, the amount almost doubled. In addition, the non-government organization ran a few hospitals such as Penang Adventist Hospital built in 1929. Public dental services prior to independence were run by British dentists in the large hospitals, assisted by locally qualified dentists who also visited towns and districts. Restricted to traditional medications and knowledge among the races. Then arrival of colonialism brought the Western medical practice into Malaysia. Then Institute for Medical Research, that's IMR, began with recommendation in 1900 from Sir Frank Athelstan Swettenham. Then Kuala Lumpur was chosen as the site for the institute. They carried out the scientific researches into the causes and treatment and prevention. So in the beginning, tertiary care, I have to go from the lower like primary and preventive care, healthcare in polyclinics, one Malaysia and one clinic. Then secondary, that is district hospital. Then tertiary, referral region and hospitals. So structure of government primary healthcare, three-tier system from 1956 to 1970. In this, level of services like main healthcare centers, health sub-centers and midwife clinics. The main healthcare center staffing pattern is like doctor and dentist, services like priority outpatient care and dental care. Health sub-centers, medical assistants and staff nurses, services, outpatient screening and maternal health care. Then midwife clinics, that is midwives, home delivery and home visits. But this system they changed in 1972 till now. They are following this system. The first is health clinics like doctor, dentist, pharmacist, assistant medical officers, public health nurses. Then outpatient services, dental care, health promotion, family planning people will be there. These are the services. Then community clinics, here community nurse and home care, family planning will be done. So healthcare system in rural areas. In terms of accessibility, almost any person has an accessible healthcare within 5 to 10 kilometer radius. There are 2965 clinics and 151 mobile clinics in rural areas in Malaysia. The most rural areas are covered by Klinik Desa, that is village clinic, and it is run by Jururawat Masyarakat. I'm sorry, I am poor in pronouncing Malay words. It is usually meant for uncomplicated antenatal and postnatal follow-up as well as vaccination. The community nurses are trained to pick up any signs of complicated pregnancy and refer to the nearest clinic kesehatan. There are usually one clinic kesehatan in small town which is allowed to treat hypertension, diabetes mellitus and simple cough and cold. A research showed that most utilized mode of primary health care in Malaysia is private sector, that is 57.2%, followed by multiple choices, that is 21.5%, public health care services is 19%. Lastly, the traditional way is 2.3%. Tradition means Chinese medicine, like that. To come to summary, many steps has been taken by our Ministry of Health in order to prevent any diseases. If the disease is already present, steps are taken to prevent progression of the disease to chronic condition. And besides that, not forgetting the MOH has taken initiative in providing healthcare services in rural areas. This is done by building up the healthcare centers and training of healthcare assistants. This directly improves the health condition among the population of Malaysia. Conclusion: Malaysia has achieved impressive health gains for its population with a low-cost healthcare system that provides universal and comprehensive services funded through general revenue. Malaysia has also developed a much admired model of comprehensive public primary health care that includes outreach services to remote areas.